Hello and good evening. I'm Melisa Idris. Welcome to Consider This. This is the show where we want you to consider and then reconsider what you know of the news of the day. Following the first meeting by the Cabinet Committee on the Eradication of Drugs recently, Law Minister Azalina Othman Said announced that the government is revising its present approach to drug dependency to now include medical intervention, treatment and rehabilitation. This in recognition that drug abuse disorders are a medical condition. Now, the government is currently studying two proposals. The first, a sentencing council to review all criminal sentences, including those for drug offences. And second, to promote community-based rehab instead of imprisonment. The government is calling this a game-changer approach. So here to help us probe this further is Dr. Sangeeth Kaur, co-chair of the Expert Advisory Group on Drug Treatment and Rehabilitation in East and Southeast Asia under the United Nations Office on Drugs and Crime. Dr. Sangeeth has long been an advocate for drug policy reform in Malaysia. We are delighted to welcome her to the show. Dr. Sangeeth, can I get your initial thoughts on the government's announcement? Is this the game changer it's touted to be?
Hi, Melissa. Thank you. I think I'm really excited to be here. I think what we have witnessed is a very courageous forward move, thinking progressive step in recognizing that addiction or drug addiction and use of illicit substance is actually a medical condition. It is a chronic relapsing disease that actually needs biopsychosocial intervention, including medical treatment, psychosocial interventions, and in the community and not in incarcerated settings. I think we are aware that in Malaysia, we have lost the war on drugs like all the other countries in the world. And this is because we've been using draconian punitive drug laws like the Dangerous Drug Act 1952, whereby we have been compulsory incarcerating for people who use substance into pusat serentis, prisons, and using very non-humane methods like cold turkey detoxification, abstinence-based treatment, which can be very painful. So I think in recognizing that it's a medical disorder, we are actually creating the awareness that it's a compassionate strategy in addressing addiction, and that they are humans and not sampah masyarakat, and and this I think will alleviate the fear among the people who use substance to actually seek treatment without the fear of criminal penalties, without the fear of being arrested. Families could take their children to rehabilitation programs without the fear of being arrested or being urine tested. So I think it's so progressive if we are able to move forward with this strategy and addressing the drug laws. And I think with this, we will be able to integrate, with the new drugs in the market, we'll be able to integrate more of psychiatric treatment, mental health treatment, together with psychosocial treatment and other interventions in the community.
Okay, so I want to kind of hone in on the what community-based rehabilitation means, because part of the proposals to change the present approach is to promote community-based rehab instead of imprisonment, particularly for first-time offenders, for those who are sentenced to less than 3 years imprisonment. Talk to me about what that means. What is this concept of community-based rehabilitation? How is it different in its from the traditional approach of incarceration, particularly for people who use drugs?
Okay, so from what we know, traditional incarceration is irrespective of the category of substance use. So I think we have come to a stage where we need to start identifying. So the laws now, they do not categorize substance use. You can be a one-time user, experimental user, casual user, regular user, and then finally you could be dependent on substance. So our laws, we don't categorize the individual. One law is for all of anyone who uses illicit substance. So traditionally incarceration, which also meant compulsory detention, is where we are taking anyone who is either experimenting or even just a first-time user, and we are actually taking them away from incarcerated in compulsory detention center and hardcore drugs. They are more exposed to hardcore prisoners, and they come out uh, knowing much more than what they knew, or are using more hardcore drugs. And when they come out with a criminal record, which then does not allow them to get a job, and also the stigma and discrimination that doesn't allow them to reintegrate back in the society, and it's a vicious cycle. So I go to Kajang prison, and I see, if they're in there for drug use, um, they've been there 40 times, 35 times. Yeah, it's amazing. And I think the big problem is like, we need to identify if they we are not I'm not advocating for legalization of drugs, but we are addressing people who are incarcerated for minor drug offenses, for possession, for personal use. I mean, it's a totally different story with the trafficking of substance use. But I think for personal drug use, it's a huge problem. 60% of the prisons are filled with people who use substance for personal use, and this really needs addressing. And other than that, the risk of HIV, tuberculosis in incarcerated. So that was what has been going on till now. So community-based treatment is that we are able to recognize the problem in the community. We're able to identify, screen them to see, are they recreational users? Are they casual users? Do they actually need treatment? Do they need rehabilitation, or do they just need awareness? What is their social surroundings? Are they employed? We need to address all these issues. And I think this can't be done by the enforcement agencies. It has to be done by the civil society organizations in the community.
Oh, I see. So just sorry, just to jump in. So when we say community-based rehabilitation, community that's the role of community, civil society, neighborhoods, family. Is that the community that we're talking about?
Yes, including, I mean, if required, they can always seek treatment at we want to address it as a public health problem. Like if they require further medical treatment, they can always access the treatment in the clinic kesihatan or the hospitals, so it can be with different tasks. Uh, multidisciplinary with different agencies that we strongly we are against arrest of people who use for their own personal use.
Okay, so you said that this will be a game changer if it manages to be implemented well. Can I ask you, just based on your work and your experience, what would you consider barriers or challenges to getting this right, to implementing this community-based rehabilitation program, to make sure that it's working the way it was intended?
Explaining that not everyone is the same. I think there was a study done recently in UKM where I think 6 out of 100 youth had experimented with substance use. So imagine if anyone who experimented ended up in prison. We need to educate the difference of who is a trafficker, who is a user, who is dependent on substance. Do they have other problems? Secondly, I think we need to have a independent committee with experts from all the Ministry of Health, from the Ministry of Home Affairs. I think everyone needs to work together. And currently, because the National Anti-Drugs Agency, the Drug Treatment Rehabilitation Act, and it's all under the Ministry of Home Affairs. So I think there's a lot of I understand there's a balance between security and rehabilitation. So I think we need to look at the drug law, whether Ministry of Health needs to play a bigger role. So a national committee with all the relevant stakeholders to sit together and come up with a very comprehensive new drug policy. Other than that, I think we need funding. I think the civil society, funding for the civil society, so that they can undergo training, we can train them, and more to expand the community services in the community. Training, we need to train even our police officers, enforcement officers, to change to work towards diversion. That means diverting them towards, they can continue their work, but instead of arrest, you divert them, just like what's happening in Portugal and a lot of countries, where if a police the police are seen as people who are going to help you and not somebody who's going to arrest you. So police help to divert them to treatment, rehabilitation. We need to train more medical, social workers. We also need to educate the criminal justice system, lawyers, the judges. There could be some resistance, because it's been since 1952 using the Dangerous Drug Act. So we need to train them. We need to abolish all the criminal records of people who use drugs so that they can come out and they can actually gain employment. And also at the moment there's a lot of good programs that are happening in the country.
Dr. Sangeeth, that sounds like a long laundry list of things to do, but all a holistic approach, because almost everything in the ecosystem needs to change to address this. The Deputy Prime Minister has given a 3-month timeline to get the coordination efforts streamlined. Is that an unrealistic time frame? What would you like to see happen, at least in the first 3 months, as someone who has been working on drug policy reform for many, many years?
So I think the first step is definitely forming a national committee with experts to actually, within the 3 months, to review and to come up with a draft of a working work plan. So our group, we've been working very hard on developing a work plan, a national work plan, on moving towards to review the national drug policy. So I think within the 3 months, if we are able to form the committee and form the branches and get the experts to sit together and to draft a work plan, it can't be done overnight. It can't be done in 3 months. It's going to take years, but to have a workflow and so that it is independent and not dependent on the sitting government, or it should be an ongoing process.
Dr. Sangeeth, thank you so much for joining me on the show. Dr. Sangeeth Kaur, co-chair of the Expert Advisory Group on Drug Treatment and Rehabilitation in East and Southeast Asia under the United Nations Office on Drugs and Crime. We're going to take a very quick break here and consider this. We'll be back with more. Stay tuned. Welcome back to Consider This. I'm Melisa Idris. Let's continue our discussion about the recent announcement by the government that it is revising its present approach to drug dependency to now include medical intervention, treatment and rehabilitation. Joining me now is Professor Vicknasingam B. Kasinather. He is from the Center for Drug Research at USM, where he focuses on understanding and developing behavioral interventions for people who use drugs. Since 2015, he has been a member of the Scientific Advisory Committee of the United Nations Office on Drugs and Crime, at Drugs and Crimes World Drug Report. He's also been a consultant for the WHO and UNDP on issues related to drug use. Professor Vickna, thank you for joining me on the show today. I'm wondering if we could begin our conversation with an overview of the current system that Malaysia has in place for dealing with people who use drugs. Who are the key agencies that are involved in the process? What happens to a person who uses drugs when they are, taken in by the police? What happens to them in the system?
Okay, thank you for having me on the show. The two main agencies are the police, the Royal Malaysian Police Narcotics Investigation Department, and the National Anti-Drug Agency are the two main agencies, but at the same time, the Ministry of Health also plays an important role. But over the years, the police and the National Anti-Drug Agency plays a larger role, while the Ministry of Health could come in and play a bigger role, which I believe they should come in and play a larger role in the current system.
Okay, so PDRM and NADA, the National Anti-Drug Agency, they are both under the Home Ministry. Home Ministry looks at inland security, national security threats. Is that the approach that we are using currently, that drug users are seen as a national security threat, and why so?
That was the approach. I think many countries in the world adopted that approach simply because we did not understand drug addiction at that time. The medical evidence, the science behind addiction was not well understood. So it was always perceived to be as a security national threat. Hence, it coming under the Ministry of Home Affairs. But now it's become very clear from research that we have done. We understand that it is a medical condition. So it should not come under the Ministry of Home Affairs. And it is very clear, not only in Malaysia, all around the world, locking people up, incarcerating people who use drugs simply does not give us the best results. We're just going around this vicious cycle, putting people in and out of prison, really not solving the problem. And there's a financial implication to this as well. It's much more expensive to incarcerate someone than to provide medical interventions.
Yeah, I can imagine, right? How much money has been spent on the war on drugs, which has failed. Can I ask you?
I'll give you an example.
Oh, okay.
We did a study some time back, and we found that keeping someone in the prison costs about 20,000 ringgit a year per person per year, and keeping someone incarcerated in the AADK's rehabilitation center, institutional rehabilitation center, costs about 38,000 per person per year, while providing medical interventions in the community only cost about 6,000 ringgit plus minus a year. So you can see the savings that you can have with better outcomes.
Okay, all right. So when we think about this new approach, about the evolving approach to how people who use drugs are within the system, in the context of the police, what role would the police then play for this? How might their role evolve from just a drug enforcement perspective?
I think the police can continue their efforts with supply reduction. They can concentrate their efforts, focus a lot of their human resource towards reducing the supply. We don't have a problem with that. I think that has to be dealt with severely. People who traffic drugs, but certainly people who use drugs should be, channeled towards the medical-based interventions should be provided to them. And I think even the National Anti-Drug Agency, which they never had enforcement powers when they were first set up, they only were supposed to provide treatment, rehabilitation, as well as prevention. The enforcement component for the National Anti-Drug Agency came about 10, 12, something I think they should not be having. It's a duplication of what the police is doing. They should, really focus their efforts on prevention, treatment, and rehabilitation.
Oh, I wasn't aware that NADA had enforcement authority. So are you saying that they can also make raids and arrest people at the same time looking at rehabilitation process?
That's right, and that's precisely the problem. When someone wears two hats, and if you go out there and talk to many people who use drugs, the level of trust towards this agency may not be, because someone that says they're going to treat you and rehabilitate you, but at the same time they can also arrest you. So that level of trust simply won't be there. So my recommendation is for them to not have enforcement power, but they have a large role to play in the prevention and treatment and rehabilitation areas.
Okay, could you elaborate on that? What would you like? How would you like to see NADA's role evolve, particularly under this new approach of rehabilitation and not incarceration?
I welcome the recent announcement by the minister and the government that they are moving towards providing community-based rehabilitation. I think that's certainly the right way to move, and I think that's where the world is moving based on the evidence. But what I would like to see is NADA having more consultations with stakeholders, because if you're going to have community-based rehabilitation, you've got to get the community involved. Uh, my colleagues and me working in this area, so far we have not been consulted. Uh, it's not only academics and the research fraternity, but more importantly, also the civil societies. They have their pulse on the ground. They know what's going on the ground. So if we're going to have community-based rehab, then you definitely need to get the other stakeholders, consult them, discuss with them, and whatever the approach has to be evidence-based. It has to be evidence-based, based on science and research. So this is what I would like to see NADA doing.
Okay, when you talk about community-based rehabilitation, is there still a role for enforcement agencies, for NADA, for KKM? I'm just wondering where that role might come in. And also, earlier in my conversation with Dr. Sangeeth Kaur, she used the term sampah masyarakat, how people who use drugs are often seen by the community through this lens. How do we ensure that that changes, that the community wants to participate in community-based rehabilitation? Key, so vital for its success.
Yeah, I think first we need to address the issue of stigma. We continue to use the word drug addicts. Today, if I'm writing a scientific paper and if I'm going to publish an article in a scientific journal in the area of addiction, the moment you write the word drug addict, it's not an acceptable term anymore. So the term that we should be using, which is a medically accepted term, is people who have substance use disorder, SUD. So the term drug addicts itself is very stigmatizing. Uh, we continue to use it very loosely. I think the media should also learn to change its framing, language and communication. Society needs to be sensitized about how this is a medical condition rather than a social problem or a security threat. you know so this kind of messaging and framing has to take place in society to make people understand. I remember when COVID first came, there was a lot of stigma around people who got COVID in the first 6 months or so of COVID, and then people got to realize that it's not bad. And then the stigma gradually reduced. So we need to think of, if you're going to have community-based programs, you've got to work with society, and then getting all the community stakeholders involved. And I think, one of the best examples we have had success is, if you remember the turn of the century, Malaysia's HIV infection rates were driven by injection drug use. And, we had a lot of discussion about giving needles to drug users at that time. It seems like we were encouraging drug use, but that intervention was very successful, largely because we worked with community-based organizations. Civil societies played a large role in that program. And within several years, the HIV infection rates among injecting drug users reduced from 80% to about 10%, very drastically, very quickly. So this community-based rehab definitely is a great model, but all stakeholders need to play a part.
Okay, very quickly, Dr. Vickna, can I ask you, in this 3-month timeline that the Deputy Prime Minister has given for streamlining coordination efforts, where would you caution as areas of hazard, if I may, in implementing some of these proposed reforms?
Like I said earlier, I think first thing is consultation needs to take place. That has, at least to my knowledge, that hasn't taken place yet. NADA has not consulted. Secondly, I think relevant laws need to be changed, because the Dangerous Drug Act, if you look at the act itself, it's very old. There are a lot of laws that are not relevant anymore. For example, there's section 15(1)(a) of the Dangerous Drug Act, that someone can be sent to prison or fined for merely a positive urine. A positive urine is a diagnosis that's used to just identify if someone has used drugs or not. but it does not tell you the severity of the drug of drug use of that particular individual. So
Right.
laws like this need to be relooked. So 3 months is a short period of time, but at least a consultation should take place. Relevant laws that are probably outdated can be identified uh, and then looked at more seriously by the legal people.
Right. Thank you so much for speaking with me. That was Professor Vicknasingam B. Kasinather from the Centre for Drug Research at University Science Malaysia. That wraps up this episode of Consider This. I'm Melisa Idris, signing off for the evening. Thank you so much for watching, and good night.